is rarely indicated. However, in adults, especially in older groups, effective operative repair is worthwhile. Relatively commonly, rectal prolapse is found to be associated with or related to neurologic and psychiatric disorders, as well as degenerative arteriosclerotic diseases. True prolapse of the rectum involves a herniation of the pouch of Douglas through the dilated and incompetent sphincter muscles. To correct this defect, the hernial pouch must be eliminated and the weakened pelvic floor strengthened. Obliteration of the pouch of Douglas and fixation of the rectum can be accomplished by the perineal, abdominal, or combined approach. True prolapse of the rectum starts as an internal intussusception at the level of the levator muscles anteriorly. The rectum slides from this weak point through the anal canal. A true prolapse can be identified by circular rings of the prolapsed rectum as all layers of the bowel are present. In a first-degree prolapse, only the mucosa of the bowel is prolapsed, which is usually identified by 3 radial folds rather than circumferential folds. Rectal prolapse, if allowed to persist, can result in dilatation and incompetent anal sphincters. Prolapse is often present in elderly women who have perineal descent and weakness of the pelvis floor muscles. Perineal descent may often be associated with either a retocele or a cystocele. There is often an antecedent history of multiple pregnancies in pelvis. Surgery including hysterectomy. Operative correction by the perineal approach is usually reserved for individuals who are elderly and would otherwise be unable to tolerate a sigmoid colectomy and rectopexy, which is the ideal repair for this problem. Colonoscopy or a barium enema and sigmoidoscopic examination are essential. The use of a low-residue diet, cathar tics, and enemas is necessary to obtain a clean and empty large bowel. The prolapse is reduced and reduction sustained by the application of AT binder to minimize the associated edema and encourage the healing of any superficial ulcerations. The procedure requires a complete bowel prep including both mechanical cleansing and oral and preoperative intravenous antibiotics, general or spinal. Anesthesia is satisfactory. However, general is usually preferred. The patient is placed in a lithotomy position with the legs widely separated. The table is in a slight Trendelenburg position. To decrease the venous ooze and enhance the anatomic dissection, the prolapse is reduced and the rectum irrigated with sterile saline. The skin about the perineum is cleansed in a routine manner. The area may be dried and a plastic drape used if desired. The bladder is catheterized, and the catheter left in place. The prolapse tends to present without difficulty, figure 1, and Babcock or Alice forceps are applied for traction purposes to determine the extent of the prolapse. The relationship of the prolapse to the pouch of Douglas and the sphincter muscles of the anus is shown in figure 2. The protruding mass is palpated to make certain the small intestine is not entrapped in the hernia sac anteriorly. Absorb-able 000 sutures are placed in midline, figure 3a, anteriorly, posteriorly, and at the halfway point on either side, figure 3b and b1, near the anal margin, not only to serve as a retractor but for subsequent landmarks at the completion of the procedure. The identification of the pectinate line is important, since the incision through the presenting rectal mucosa will be made 3 mm proximal to this anatomic landmark. This minimal amount of mucosa is adequate for the final anastomosis and is short enough to prevent postoperative protrusion. A sharp knife or electrocautery can be used, figure 3. This area tends to be quite vascular, and meticulous hemostasis by electrocoagulation or individual ligation is essential, figure 4. The incision through the outer sleeve should divide the full thickness of bowel wall, including mucosa as well as the muscularis. The pouch of Douglas is not entered. The dissection is facilitated if the surgeon inserts his index pharyngeal in a developed cleavage plane between the two layers of prolapsed bowel wall, figure 5. After the mucosa and muscularis of the protruding segment have been completely divided. Traction is maintained downward on the cuff of incised mucosa and muscularis, figure 6. Any attachments between the bowel wall and the underlying segment are divided with the electrocoagulant unit or sharp knife, and all bleeding points are controlled. This cuff is pulled off easily and results in a segment twice as long as the original protrusion, figure 7. The bowel wall is not amputated at this time, but downward traction is maintained as an attempt is made to identify the prolapsed pouch of Douglas, figure 7. The resection may be started in the midline anteriorly and continued upward through the fat until the glistening wall of the peritoneum is identified. The peritoneum is gently opened, figure 8, and the pouch of Douglas is explored with the examining finger. Any attachments between the small bowel or adnexa in the female should be separated to ensure freeing of as much of the pouch of Douglas as possible and to permit mobilization of the redundant rectosigmoid into the wound. After the peritoneum is opened, the presenting intestine lying on the posterior side of the sliding hernia is grasped with forceps to determine how much mobile large intestine will require amputation to correct the tendency toward recurrent prolapse. The peritoneal opening should be extended laterally to either side. The blood supply, surrounded by a thick layer of fatty tissue, is usually identified posteriorly and on the right side of the presenting intestines. Figure 9. Half-length forceps and the surgeon's index finger are used as blunt dissectors until the mesentery to this segment of the bowel has been separated without injuring the bowel wall itself. At least 3 half-length clamps are applied to ensure a safe double ligation with zero absorbable suture, figure 10. The most proximal one of these sutures should be of the transfixing type, since the tissues are under some tension, and bleeding may develop unless the contents of these clamps are tied securely. No effort should be made to strip the bowel from the mesentery. However, it may be necessary to reapply clamps from either side, as well as in the midline posteriorly, until all the redundant large intestine has been pulled freely into the wound after the blood supply has been ligated and as much of the intestines as necessary mobilized into the wound. The pouch of Douglas can be closed in several ways. If the opening is rather large and the prolapse has included a segment of the large intestine well above the base of the pouch of Douglas, an inverted T-type closure of the peritoneum can be carried out, figure 11. The peritoneum is closed in the midline anteriorly with interrupted or continuous OO absorbable suture. The closure approximates the peritoneum around the bowel wall, and the continuous suture is tied. A suture starting at this point, including a bite of the peritoneum as well as of the bowel wall, continues around to the right side until it is anchored in the region of the ligated mesentery blood supply, figure 11. The attachment of the peritoneum is made secure in a similar manner on the left side. This accounts for the so-called inverted T closure of the peritoneum. In some instances, especially when the prolapse is not particularly marked, the pouch of Douglas may be developed from the anterior rectal wall similar to a direct hernial sac, figure 12. The peritoneum is then carefully incised and the margins held apart by traction with 2 or 3 forceps, figure 13. The surgeon's index finger should be inserted to ascertain that the pouch of Douglas is free from attachments to either the small bowel or the adnexa in the female. It may be necessary to enlarge such an opening and insert a small retractor to accomplish this with good Visualization. The pouch of Douglas should be closed as high as possible with a purse string 00. Absorbable suture, figure 14. Considerable time may be required to make certain that the pouch of Douglas has been obliterated as high as possible. If the obliteration cannot be done satisfactorily, it may be judicious to obliterate the pouch of Douglas by a transabdominal approach as part of a plan for a second stage or a two-stage procedure. After the peritoneum has been closed, the redundant peritoneum is amputated, and additional sutures are taken to control bleeding and reinforce the pouch of Douglas, figure 15. The next step involves identification of the levator muscles, since the reinforcement of the pelvic floor is essential to prevent recurrence. The procedure to be followed is not unlike the approximation of the levator muscles in the performance of a posterior purine orifice. A small narrow retractor can be inserted anteriorly as the surgeon inserts the index and middle fingers of the left hand to better define the levator ani muscles on the left side. An Alice or Babcock clamp grasps the levator muscles to better define their margins, and a deep OO absorbable suture is inserted, figure 16. The first suture can be applied at either the top or the bottom of the proposed closure, depending on which is easier. In figure 17, the first suture shown is placed in the bottom of the approximation, and a right-angle clamp depresses the bowel wall to provide a snug approximation by the levators. An additional 3 or 4 sutures are required to approximate the levators farther up in the midline, figure 18. Only after the levators are approximated should the prolapsed bowel be prepared for amputation. It is essential that the normal anatomic position of the bowel be retained. For this reason it has been found judicious to split the anterior as well as the posterior wall of the prolapsed large intestine almost up to the region where the bowel will be divided. This should be done carefully so that sufficient bowel is available for approximation to the pectinate line, yet a sufficient amount is removed to prevent recurrence, figure 18. After the bowel has been divided, the surgeon should insert a finger into the lumen of the bowel to again check snugness of the approximation of the levator muscles. Enough room should be available to admit the index and middle fingers easily. If the approximation of the levators seems to be too snug and the blood supply to the bowel compromised, one of the sutures may be removed, or, if too large, an additional approximation of the levators should be considered before the bowel wall is divided up as high as eventually required. The midline anteriorly should be tested for length. The bowel wall is divided up to a point where a retraction suture can be placed in the midline approximating the mucosa with the pectinate line without tension, figure 19. A quadrant of the mucosa is then divided, and the mucosa is approximated to the pectinate line with either the continuous lock or interrupted OO. Absorbable sutures. The mucosa can be approximated more accurately if a planned quadrant anatomic fixation is carried out as shown in figures 19 and 20. The importance of the traction sutures in the midline and at the halfway point on either side readily becomes apparent as the satisfactory approximation of the mucosa to the pectinate line is finally accomplished. Figure 20. The should be an easy approximation of the mucosa to the pectinate line, and it should have a nice pink color. The sutures should not be tied so tight as to produce bleaching of the mucosa. After completion of the procedure, the surgeon should introduce a well-lubricated finger carefully through the anastomosis to make certain of its patency as well as its adequacy. Figure 21. No drainage is indicated. Antibiotic therapy should be considered for about 3 or more days. Fluid balance is maintained by intravenous administration of water, glucose, and Electrolytes. A liquid diet is gradually progressed to a low-residue diet. Mineral oil in doses of 1 ounce 2 times per day is given. Digital examination is delayed unless undue distress develops. About the site of operation. The possibility of development of a perirectal abscess, which may require incision and drainage, is an ever-present threat.